Imagine waking up in a room where you just can't quite remember how you got there.
Right, which sounds incredibly disorienting right from the start.
Exactly. The lighting is completely unfamiliar. You hear, like, strange noises down the hall, and
And
then,
then a total stranger walks in and starts pulling at your blankets.
yeah, and trying to take off your clothes. I mean, how would you react to that? You'd be terrified,
You'd probably fight back or, maybe scream or just completely shut down.
which is a deeply visceral scenario. But honestly, it's the exact reality for thousands of long-term care residents every single day.
Because when memory fails, the world just becomes a very threatening place.
It really is. And navigating that fear, uh, understanding the actual human being behind the diagnosis, that is exactly what we're getting into today. So a massive welcome back to the Cert Prep Academy CNA Exam Prep Podcast.
We are so glad to have you back.
Yeah. And if you are just joining us for the first time, this is an 11-part series covering all 6 of the NNAAP written exam topics.
And the really great thing is that each of these stands completely alone. So you can just jump around to whatever topic you need most for your studying right now.
Today is episode 10, which covers psychosocial care. So that's communication, mental health, and end of life.
It's a heavy one, but super important.
Definitely. Our mission today is a complete deep dive into the source material, focusing entirely on the psychosocial side of nursing.
We've got a mountain of practice scenarios to get through.
Oh yeah, we are going to dissect the underlying mechanisms of every single one. But before we get into the psychological weeds, let's look at the actual NNAAP test structure. Like, how much of the exam actually focuses on this kind of emotional care?
It's actually a surprisingly significant chunk. If we break down the 2016 NNAAP written exam content outline, the test has 70 total questions.
Right, and 10 of those are pre-test items, correct?
Exactly, so they aren't actually scored. But of the 60 scored questions, psychosocial care skills make up 11%.
Okay, so that translates to what, 6 questions?
Yeah. Yep. 6 questions. Then spiritual and cultural needs account for another 2%, so that's 2 more. And then the communication portion under the AIDS role is 8%.
Which gives us 4 more questions. So we are talking about 12 scored questions out of 60 that lean heavily into, well, how you talk to, listen to, and emotionally support your residents.
Right. That is a full fifth of your exam score right there.
Which is massive.
It is. And the reason we really need to dig into this is that these scenarios, they often seem like they have more than one right answer if you're just relying on your everyday human intuition.
Because the exam isn't testing how you talk to your friends, is it? It's testing a very specific clinical approach to empathy.
Exactly.
Okay, let's unpack this. Because before we can even get into the nuances of specific mental health conditions or like dementia care, we really need to define what the CNA's actual role is.
Yeah, the source material draws a very hard line regarding scope of practice.
So where exactly are the boundaries? Like, what does the source material say?
That's the perfect place to start. The literature explicitly states that the CNA's role in supporting psychosocial needs is to provide basic emotional support and report changes to the nurse.
Just that baseline.
Right. That's the absolute baseline.
Because a common pitfall the exam writers use to trick people is suggesting the CNA should, I don't know, provide psychiatric counseling or something.
Or make decisions about the resident's care plan, which, sounds incredibly proactive, but it's fundamentally out of scope.
Right. As a CNA, you are the sensory network of the facility,
Yeah,
the eyes and ears.
because you spend exponentially more time with the residents than the doctors or the nurses do.
Yeah.
But you are not diagnosing them, and you are absolutely not their therapist.
You provide the emotional scaffolding, and you report.
Huh.
That brings us to the concept of therapeutic communication, especially when a resident is in emotional distress.
Which is such a clinical buzzword, right?
It totally is. It shows up in every single healthcare textbook. But functionally, what does that actually mean when you're standing in front of a crying patient?
Well, in the context of the NNAAP, therapeutic communication means providing comfort, supporting the resident, and above all, establishing trust.
And the literature strongly suggests that open-ended questions and active listening are like your primary tools here.
Absolutely. And the distractors on the exam for this concept are fascinating. They reveal so much about our natural instincts.
Oh, like choosing an action that aims to minimize resident complaints.
Yes. Or trying to distract the resident from their feelings. It's such a human reflex, isn't it?
It really is. Like, if your friend is sad, you naturally want to distract them. You say, hey, let's go get ice cream. Don't think about it.
Right, but clinically, that's entirely wrong.
So why is it wrong?
Because distraction avoids the emotion, and minimizing dismisses their reality. If you distract a resident from their grief, you are sending a subconscious message that their grief is just too burdensome for you to handle.
Oh, wow, that makes so much sense. So therapeutic communication is about having the clinical fortitude to face their emotion with them.
Exactly. So instead of changing the subject, which the exam will constantly tempt you to do, you use open-ended questions to encourage them to express themselves.
And here's another trap I saw in the source material, providing advice about their family relationship.
Oh, yeah, that is a classic boundary violation. As soon as you start giving advice about personal family dynamics, you've stepped way outside the CNA scope of practice.
Because you aren't a family therapist.
Yeah.
You listen, you validate, but you do not advise.
Let's look at how this plays out in a tangible scenario. The practice material frequently brings up residents expressing profound loneliness or maybe becoming tearful when discussing their family.
And the clinical best practice is always to listen attentively, spend time with them, and perhaps hand them a tissue.
Right. And the wrong moves are telling them to stop thinking about being alone or telling them to stop crying.
Or quickly changing the subject to something cheerful, like we talked about.
Handing them tissues is actually a form of physical validation. It's a nonverbal cue that says, I see you are crying, it is perfectly acceptable that you are crying, and I am here to support you through it.
I understand that intellectually, but I have to push back on this a little bit, just from the perspective of someone stepping into healthcare for the first time.
Sure, go for it.
Isn't our job to fix the problem?
Mm-hmm.
I mean, if a patient is sad, shouldn't we actively try to cheer them up? It feels almost negligent to just sit there and pass the tissues.
It's a very common internal struggle for new healthcare professionals. You get into this field because you are a fixer, you know? You want to heal people.
Right. I want to make them feel better.
But you have to separate fixing from validating. Think about the mechanism of grief. If an 85-year-old resident is weeping because she misses her late husband of 60 years, no cheerful change of subject is going to fix that loss.
Because it's unfixable.
Exactly. Sometimes the treatment isn't a cure. The treatment is holding space. Being a safe, non-judgmental presence while someone processes unfixable pain is a highly active, deeply vital clinical skill.
That makes a lot of sense when you frame it as an active clinical skill rather than just like passive listening. And, this is a question type Cert Prep Academy uses a lot for this topic.
Oh, absolutely.
Yeah, testing. If you know where the CNA's job ends and the nurse's or therapist begins, you aren't there to magically erase the grief. You're there to ensure they don't have to experience that grief completely alone in a sterile room.
You are laying down the foundation of trust.
Well, building on this idea of validation, let's shift to how this applies to residents with cognitive impairment. Because if validating their reality is the baseline for daily care, what happens when their reality looks completely different from yours due to dementia?
Dementia and Alzheimer's change the entire communication landscape, and the source material highlights a very specific, incredibly common neurological phenomenon that you will absolutely see on the exam.
Which is sundowning, right?
Yes, sundowning.
The literature defines sundowning as a state where a resident with dementia becomes agitated, restless, and confused, specifically during the late afternoon and evening hours.
And the exam writers love to throw in distractor terms for this, like delirium or wandering syndrome.
Delirium is a fantastic trap, actually, because delirium also involves acute, severe confusion.
It does, but delirium is almost always caused by a sudden underlying medical issue.
Like a severe UTI, right? Or dehydration.
Exactly. Or an adverse medication reaction. Sundowning, on the other hand, is a specific, predictable circadian pattern of agitation linked directly to the progression of dementia.
So when you are faced with a resident who is actively sundowning, the source material emphasizes a very specific first response protocol. You speak calmly, orient the resident to person, place, and time, and crucially, reduce environmental stimuli.
Because the alternative options presented on the exam are genuinely dangerous. One common pitfall suggests notifying the nurse that the resident is being difficult.
Which implies the resident is intentionally misbehaving. That completely ignores the clinical reality of a feeling brain.
Right. And another trap suggests you should engage them in physical activities to tire them out.
Which honestly sounds incredibly logical if you're comparing it to dealing with a cranky toddler. Like, oh, they're agitated. Let's let them walk the halls and burn off that nervous energy.
It sounds logical, sure.
But functionally, why is that the wrong approach for a sundowning adult?
Because you have to look at the neurology of what's happening. Sundowning is heavily linked to sensory overload and cognitive exhaustion.
Ah, okay.
Imagine your brain has been working tenfold all day just to interpret basic light, sound, and language. By 4 p.m., the brain is just exhausted.
So the shadows in the room start to look threatening.
Exactly.
Yeah.
The noise of the dinner cart sounds like an alarm. If you try to tire them out with more physical activity, you are just pouring more sensory input into an already overflowing, overwhelmed brain.
They don't need more stimulation. They need a dramatic reduction of it.
Precisely. You dim the harsh lights, turn off the television, reduce the background noise, and speak in a low, soothing tone.
That transition from overstimulation to a calm environment perfectly bridges into the concept of dignity. Because cognitive impairment makes basic physical care deeply challenging.
It really does.
The source material brings up the very common scenario. A resident with advanced dementia who becomes angry and combative when it's time to be bathed.
This happens constantly. Think about the vulnerability of bathing. You are cold, you are naked, and if you have dementia, you likely have no memory of consenting to this.
Or understanding why a virtual stranger is pouring water on you.
Exactly. The fight-or-flight response kicks in immediately.
The literature strongly suggests the right approach is using gentle touch, providing simple, step-by-step explanations, allowing frequent breaks, and maintaining a calm demeanor.
But the exam will try to lure you into choosing answers that prioritize the facility's schedule over the patient's dignity.
Like delaying the bath until their mood improves.
Yes. Or even worse, bathing the resident while they are sleeping or drowsy.
Oh, wow, that's terrible. You can't just delay hygiene indefinitely because that leads to severe skin breakdown and infections, but bathing them while they sleep.
That is a profound violation of bodily autonomy and a massive safety risk. Imagine the sheer terror of waking up to someone scrubbing your body with a washcloth. It would trigger immense trauma.
Which ties perfectly into the core principle of the exam test regarding cognitive impairment, which is the vital importance of maintaining dignity and respect.
Right. It's not just about customer service. Preserving their sense of self directly promotes emotional well-being and reduces behavioral outbursts.
What's truly fascinating here is how memory loss doesn't erase the fundamental human need for respect.
A resident might not remember your name, they might not know what year it is, but they will absolutely remember the way your tone of voice made them feel. The emotional memory often outlasts the cognitive memory.
The emotional memory outlasts the cognitive memory. That is a brilliant way to frame it. And that leads us right into validation therapy and reminiscence therapy,
Which are huge topics on the test.
The exam asks what it means when a caregiver uses validation-focused responses. The clinical standard is that the resident's reality and their emotions are acknowledged as important and real, even if they aren't factually correct in our timeline.
This is a cornerstone of dementia care. Let's say you have a 90-year-old resident who is frantically packing a suitcase because she believes she needs to catch a train to go to her nursing job.
You do not argue with her.
No, you don't tell her she's 90 and retired. If you try to force her into reality, she will just feel confused and trapped. Instead, you validate the underlying emotion. You say, "You must have been a very dedicated nurse. Tell me about the hospital you worked at."
So you join them in their reality, and that connects directly to reminiscence therapy. The source material points out that listening to a resident reminisce allows them to process memories, maintain their identity, and feel valued.
But watch out for the pitfalls here. A major trap on the exam is suggesting that reminiscence therapy is used to diagnose psychiatric conditions.
Which we established CNAs do not diagnose.
Right. Another trap implies reminiscence is only beneficial if the memories are positive experiences.
Which is wild. People have complex lives. Processing hard memories or challenging times is still a vital part of maintaining their identity. You don't shut down the conversation just because the story isn't a happy one.
Exactly. You hold the space for the full spectrum of their life.
But what if they get stuck in a loop? The sources cover how to respond when a resident asks the exact same question repeatedly. And the clinical best practice is to patiently answer each time without showing annoyance.
Which, let's be honest, is incredibly difficult to do during hour 10 of a 12-hour shift.
It is. It really tests your endurance.
Yeah.
But here's a memory aid for the exam, patience over pointing it out.
I like that.
You never point out the repetition. Don't say, "You just asked me that 2 minutes ago," or "I already told you the answer." It only causes them frustration and embarrassment because to their brain, it is the very first time they are asking the question.
And if that repetition turns into a fixation, where a resident brings up a particular anxious topic constantly, the approach shifts slightly.
How so?
Well, you don't just answer it endlessly if it's causing distress. The literature suggests you listen briefly and then gently redirect the conversation while documenting the behavior.
Gently redirecting. So it's almost like you acknowledge the train of thought, but you gently switch the tracks to guide them toward a calmer subject.
Precisely. You don't ignore them, but you don't let them spiral into an anxiety loop. It's a delicate balance of validation and redirection.
All right, moving into our next major theme. We've established that cognitive impairment and physical decline can strip away a massive amount of independence from these individuals. So let's explore how CNAs can actively give power back to residents in their daily routines.
We are talking about autonomy, identity, and cultural sensitivity.
Autonomy is arguably the most critical keyword for the entire NNAAP exam. You will see it woven into almost every scenario.
You really will?
I try to think of it like this. Imagine being forced to live in a hotel where you can't pick what time you wake up, you can't choose what shirt you wear, and you have no say in what you eat for dinner.
You'd feel completely powerless.
Right. The institutionalization of care can easily make people feel like prisoners if we aren't careful.
That is the unfortunate reality for many long-term care residents if the facility staff isn't actively working to empower them with choices.
The source material explicitly asks what factor is most important when supporting a resident's sense of control. The undeniable answer is offering choices whenever possible in daily care.
Specifically things like bathing times, clothing, or meal preferences.
But we need to look at the distractor answers because they reveal the boundaries of autonomy. One trap is limiting resident choices to prevent them from making poor decisions.
That is highly paternalistic. It treats adult human beings like toddlers.
But the opposite trap is just as dangerous,
Right.
allowing residents complete freedom without any guidelines or structure.
Oh yeah, because complete freedom in a medical facility is a massive safety risk. You cannot let a resident with severe dysphagia, meaning swallowing difficulties, choose to eat a dry steak.
Because they will aspirate and choke.
Exactly. You cannot let a resident with severe balance issues choose to walk down the stairs unassisted. So the clinical mechanism here is guided choices.
Like, would you like to wear the blue shirt or the red shirt today?
Yes. Or would you prefer your shower before breakfast or after lunch?
Yeah.
You give them absolute control, but within medically safe boundaries.
Yeah, if you've been using Cert Prep Academy's flashcards, you've probably already seen this pattern emerge. Promoting autonomy is almost always going to be the right answer on the exam, provided it doesn't violate a safety protocol or a doctor's orders.
And that autonomy extends far beyond just picking out clothes. It deeply influences their spiritual and cultural identity, which is heavily tested.
The source material has several scenarios covering spiritual and cultural needs. The core principle is respecting the resident's choice to attend services of their faith and ensuring they have access to religious items.
The pitfalls here are crucial to understand for the exam. You must never discuss your own religious beliefs with the residents.
Because that is a significant boundary violation.
Right. Your personal faith, or lack thereof, has no place in their care plan. The interaction is entirely about them.
Another really interesting trap I saw in the material is telling the resident that spirituality is a private matter that should not be discussed. I can see why a test taker might pick that. Like, if religion is a sensitive private topic, shouldn't we just keep it out of the healthcare environment entirely?
It seems like the polite professional thing to do, but clinically it's incorrect. Holistic care means treating the whole person, the mind, the body, and the spirit.
That makes sense.
For many elderly individuals, their faith is their primary coping mechanism for dealing with failing health and mortality. If you tell them they cannot discuss it, you are effectively severing them from a major source of emotional resilience.
The exam also touches heavily on cultural backgrounds. The correct action is always to recognize individual differences and proactively ask residents about their preferences and customs.
The trap there is making assumptions. Just because a resident belongs to a certain demographic or ethnic group does not mean they strictly follow all the traditional customs associated with that group.
Right. Individualized inquiry is the only way to provide culturally competent care. You don't impose the facility's standard routine, and you don't avoid discussing cultural preferences just because you're afraid of saying the wrong thing.
Before we leave this section on identity, there's a specific scenario regarding negative self-image. A resident frequently makes disparaging comments about their own appearance or abilities.
They might say, "I'm so ugly now," or "I'm just a useless burden."
The literature states the most therapeutic response is pointing out their positive qualities and encouraging participation in activities. What you definitely don't want to do is ignore those statements.
Because ignoring them sends a silent signal that you agree with them.
Exactly. But you also shouldn't bluntly contradict them or argue, like saying, don't be silly, you're fine. You validate their inherent worth by highlighting their strengths and encouraging them to engage with the community.
If validating their reality and supporting their autonomy is the baseline for daily care, what happens when their reality shifts into actual clinical distress?
That brings us to our next major section, differentiating normal aging from severe mental health crises, specifically depression and anxiety.
This is a vital area for CNAs. You are the early warning system. Because you spend so much time with them, you will notice the subtle behavioral shifts of depression long before the attending physician does.
The source material provides a cluster of scenarios here. It defines the key signs of depression as a loss of interest in activities, persistent withdrawal, refusing to participate, and staying in bed most of the day.
And the correct first action is always to report these specific behavioral changes to the nurse for a full assessment.
What the NNAAP exam is really trying to hammer home here is the stark difference between normal aging and clinical depression. There is a deeply insidious trap answer that suggests frequent crying and withdrawal is normal aging behavior that does not need intervention.
There is a really dangerous misconception out there, even among newer healthcare workers, that clinical depression is just a normal, expected part of aging. Like, of course you're sad, you're old, and you live in a facility.
But the source material draws a hard line here. Aging itself is not a disease of misery. It is completely normal to experience periods of grief, especially as residents lose friends or physical abilities. But it is not normal to develop persistent clinical depression that causes a person to entirely withdraw from life.
Stop eating and refuse to leave their bed.
Right. If a resident is showing those profound signs, it is a medical crisis requiring intervention, not just a sad phase you ignore.
Another trap the exam uses is suggesting the resident who stays in bed is just being lazy.
Which places a negative moral judgment on a physiological symptom. You must never choose an exam answer that insults or blames the resident.
Then there's the scenario where a withdrawn resident explicitly says they feel useless. The clinical best practice is to acknowledge their feelings, encourage participation, and report to the nurse.
And the distractors here are genuinely terrible. One suggests assuring them that everyone feels this way sometimes.
And another suggests telling the resident they should be grateful for the care they receive.
Telling someone who is clinically depressed to be grateful is perhaps the fastest way to destroy any therapeutic trust. It induces immense guilt and entirely invalidates the chemical reality of their depression.
The material also heavily links depression to social isolation. It defines true social isolation as a prolonged lack of meaningful social contact and interaction.
Notice the crucial word there, meaningful. A resident can sit in a crowded recreation room every single day and still be profoundly socially isolated if no one is actually connecting with them on a personal level.
When addressing a resident who expresses severe loneliness, the literature says to encourage visits from family and facilitate group activities. The exam writers will try to trick you with an answer that says you should keep the resident busy with tasks to distract them.
But as we discussed earlier, distraction doesn't cure loneliness. Busy work doesn't solve isolation. Only actual human connection does.
Cert Prep Academy has some really good practice scenarios around this exact difference between clinical depression and just normal tiredness.
Yeah.
It really trains your brain to spot the keywords on the exam.
Like withdrawal, loss of interest, and persistent crying. Those keywords are flashing red lights.
Totally.
Now let's flip the coin and look at the other major mental health flag, which is anxiety.
The source material provides a scenario where a resident is showing high anxiety before medical procedure. The correct move is providing reassurance, listening to their specific concerns, and informing the nurse.
And the wrong moves are leaving them alone to calm down or minimizing the importance of the procedure.
Minimizing is when you say, oh, it's just a little blood draw, it's no big deal, you'll be fine.
To you, it's a routine task you've seen 100 times. To them, it's a massive, terrifying event. Their fear is entirely real to their nervous system.
Then we get into the physical manifestations of anxiety. The exam asks about a resident who is repeatedly pacing back and forth in the hallway. The correct response is to ensure their safety, stay nearby, and report the behavior to the nurse.
This scenario is a massive trap. The human instinct is to tell the pacing resident to please sit down and rest, or to restrict them to their room so they don't bother the other residents or get in the way of the staff.
Another trap is to just ignore it entirely, because pacing isn't actively hurting anyone. I understand why we shouldn't restrict them to their room. That borders on false imprisonment if they aren't a danger to themselves. But why is ignoring the pacing a mistake? If they want to walk, shouldn't we just let them walk?
Because pacing is an outward physical manifestation of internal psychological distress. The body is trying to burn off the adrenaline of anxiety. If you ignore the pacing, you are ignoring the distress.
So you stay nearby to ensure they don't trip or wander into an unsafe area, and you let the nurse know so the underlying anxiety can be addressed.
There's another classic anxiety manifestation in the material. The resident who frequently calls the CNA for minor, almost meaningless requests.
Well, like they dropped a napkin, or they need the blanket adjusted by an inch, or they just want to know the time.
Ah, the call light writer. Every facility has them.
Yes, and the correct approach might surprise some people. It is to respond to their calls promptly and reassuringly while encouraging independence in safe tasks.
The distractors the exam uses are to tell the resident to manage their anxiety without constant attention or to report them to the nurse as being intentionally difficult.
But you have to look at the neuroception of safety here, right? Why are they constantly pressing that button?
Exactly. They are calling because their nervous system feels unsafe, and seeing a caregiver physically appear reassures them that they haven't been abandoned. If you respond promptly, you build an intense foundation of trust. Once their brain trusts that you will actually be there when they really need you, the minor anxious calls almost always decrease.
That is a fascinating psychological mechanism. It's not about the napkin, it's about checking if the safety net is still there.
Beautifully said.
All right, let's transition into our next major section. We've talked extensively about sadness and anxiety, but sometimes that internal distress manifests outward as anger, defensiveness, or even wildly inappropriate behavior. How does the source material instruct us to handle these hard interactions?
This is the area of the exam that really tests your ability to maintain professional boundaries under pressure.
The first scenario involves a resident who becomes intensely angry and starts using foul language toward the CNA. They're just cursing you out.
The clinical standard is to remain calm, set clear boundaries regarding the language, and report the incident. What you absolutely cannot do, and what the trap answers suggest, is argue back.
You don't get into a power struggle? You don't try to lecture an agitated, potentially cognitively impaired resident about good manners?
That will only escalate the situation further, and you certainly do not just walk out of the room and abandon their care entirely out of frustration.
The literature reinforces this when discussing defensive residents. The techniques are to speak calmly, listen without judgment, and use simple words. The recurring theme across all these scenarios is de-escalation.
You have to leverage mirror neurons. If a resident is highly agitated and you respond with a loud, fast, defensive tone, their brain will mirror your stress and escalate. But if you intentionally lower your vocal register, speak slowly, and maintain a relaxed posture, their nervous system will slowly begin to mirror your calm.
Your calm demeanor is the actual medical tool that brings their emotional temperature down. But what about when boundaries are crossed in a much more uncomfortable way?
There is a scenario where a resident becomes sexually inappropriate with the CNA.
How does the exam want you to handle this safely and professionally?
The clinical best practice is to firmly but respectfully set boundaries in the moment, step back, and immediately report the behavior to the nurse.
The trap answers here are very telling. They suggest shaming or scolding the resident harshly, or permanently avoiding the resident in the future. I can completely understand why a new CNA might just want to avoid that specific resident forever. It is an incredibly uncomfortable, violating situation.
It is deeply uncomfortable, but permanently avoiding them constitutes abandonment of care, which is illegal. And shaming them is clinically inappropriate because, especially in residents with dementia or brain injuries, sexual disinhibition is often a neurological symptom of their disease.
As the brain deteriorates, they can lose the frontal lobe filtering that dictates what is socially acceptable.
They aren't always acting out of malice, they're acting out of brain damage. You simply state firmly, "Please do not touch me there. That is inappropriate." You ensure you are at a safe distance, and you report it.
Another tough interaction covered in the sources is the refusal of care. How should a CNA approach a resident who flat out refuses a bath or a treatment?
The right answer is to calmly explore the reason for the refusal, report it to the nurse, and ultimately respect their autonomy. You never, ever force them physically. You never use guilt or shame to coerce them into accepting care.
But you also don't just say, okay, fine, and walk away without digging deeper.
Right. A major pitfall is choosing an answer that says, document the refusal and take no further action. If a resident is suddenly refusing a shower, there's almost always a hidden mechanism at play. Maybe they are experiencing new physical pain. Maybe they are freezing cold.
Maybe they slipped last week and are terrified of falling again.
If you gently explore the why behind the refusal, you can often solve the underlying problem, like offering a bed bath instead, or turning up the heat, and get them the care they need while still honoring their autonomy.
Okay, we need to talk about the absolute emergencies in the source material. These are the scenarios dealing with the heaviest issues, suicide and abuse.
The first scenario is a resident expressing suicidal thoughts directly to the CNA. The absolute, undeniable correct action is to report it immediately to the nurse and document exactly what was said.
It is a profound medical emergency, full stop. The trap answers the exam uses here are terrifyingly dangerous. One suggests you should ask the resident not to tell anyone else about these feelings.
Another implies you should try to counsel them yourself to protect their privacy. You must never, ever keep a dangerous secret in a healthcare setting. If a patient expresses a desire to die, you do not promise confidentiality. You report it immediately to the charge nurse.
And the scenario regarding abuse is very similar. A resident discloses that they are experiencing abuse or neglect. The correct answer is to report it immediately to the nurse and document it according to the facility's strict policy. You are a legally mandated reporter.
But the trap answer here is one that frequently trips people up because it sounds so proactive. It suggests you should investigate the situation independently to gather more details before reporting.
I mean, I have to push back just a little. If a resident tells me someone hit them, shouldn't I at least ask a few clarifying questions? Like, who did it? When did it happen? Doesn't that make me a better advocate?
It sounds like you're being a good advocate, like a detective trying to build a case. But in reality, if you start interrogating the resident, or worse, questioning other staff members, you can severely compromise an official legal investigation. Even worse, if you tip off the abuser, you put that resident in immediate life-threatening danger.
You do not investigate crimes.
You report the disclosure straight up the chain of command, instantly.
So when looking at these extreme scenarios, the overarching lesson for the test taker is clear. You never keep dangerous secrets, you never play detective, and you stay strictly within your scope of practice as a reporter of facts.
Perfectly said. That is exactly what the exam is testing.
All right, as we move into our final section today, we're touching on perhaps the most sensitive area of psychosocial care. It requires every single therapeutic communication tool, every ounce of validation, and every boundary we've discussed so far. We're talking about end-of-life care and the complex navigation of grief.
This is an area where a caregiver's own personal discomfort with mortality often severely gets in the way of providing good clinical care.
Let's look at the first scenario. A resident expresses a profound fear about dying. The literature states the best response is to listen with empathy, hold space for that fear, and inform the nurse so additional support, like a chaplain or a social worker, can be offered.
We really need to look at the wrong answers here because they reflect exactly what untrained people do in real life when they are deeply uncomfortable with death. One trap is to change the subject immediately.
The other, more insidious trap is to provide false reassurance that death will not happen. Like, oh, don't talk like that, you're not going to die, you've got years left.
When you take the free practice test on CertPup Academy, you have to watch out for those false reassurance answers. They sound so kind and optimistic, but clinically, they are always wrong on the NNAAP.
Always.
Let's look at the psychology of false reassurance. If a patient is expressing a very real, terrifying fear about the end of their life, and you cheerfully say, "You'll be fine," you haven't comforted them. You have built a massive wall between you and them. You have effectively told them, "I am too fragile to handle your reality."
They will instantly realize you are not a safe person to talk to, and they will be forced to face their death entirely alone.
You have to swallow your own discomfort, listen with deep empathy, and sit with them in the dark.
Wow. That mechanism of isolation is heartbreaking. The material also covers the grieving process of the residents themselves. There is a scenario where a resident refuses to eat and appears completely withdrawn after receiving news of a loved one's death.
The correct response is to report the physical changes, like not eating, to the nurse, while providing continuous emotional support during their grief.
The traps are telling them to get over it, which is obviously cruel, or moving them to an isolated room so they don't upset others.
Grief is a normal, necessary human process. You don't cure it, but it still requires intense clinical monitoring, especially if the psychological pain begins to cause physical decline, like severe weight loss or dehydration.
And finally, there is a scenario regarding a resident who recently lost their spouse. How can the CNA best support their emotional well-being? The clinical standard is to listen without judgment if the resident wants to talk, and to actively allow the expression of grief.
I want to point out one specific trap answer here that catches so many people. Tell the resident that their spouse is in a better place now.
People say that at every single funeral. It's the most common phrase of comfort in our society.
They do, and it is almost always said with the absolute best of intentions. But on the exam and in clinical healthcare practice, it is completely incorrect. First, you are providing spiritual reassurance, which steps way outside the CNA scope of practice. Second, it assumes you know the resident's specific religious beliefs regarding the afterlife, which you might not.
And third, even if they are deeply religious, telling them their spouse is in a better place inherently minimizes the agonizing pain they are feeling right now.
It makes them feel guilty for being sad. Allowing the raw expression of grief without trying to put a positive spin on it is always the most therapeutic route.
That is incredibly powerful. We have really covered a massive amount of ground today, diving deep into the psychology behind the care. Let's do a quick 1-minute recap of the core takeaways.
Let's do it.
When it comes to psychosocial care on the exam, your role as a CNA is to provide comfort, establish trust, and be the eyes and ears for the nursing staff. You do not diagnose, and you do not provide psychiatric counseling.
When dealing with dementia or sundowning, you validate their reality rather than forcing them into yours, and you reduce environmental stimulation rather than increasing it.
You promote autonomy by offering guided, safe choices, like picking out clothes or shower times. You maintain a calm, de-escalating tone when faced with defensiveness. You avoid false reassurance at all costs.
And above all, if you encounter an absolute emergency like suicidal thoughts or a disclosure of abuse, you do not keep secrets, you do not investigate, you report it immediately to the charge nurse.
That is a flawless summary of the exact clinical mindset you need to pass the psychosocial portion of the NNAAP exam. And listen, if you want to test yourself on everything we just talked about today, certprepacademy.com is completely free.
Completely free.
There is no sign-up required to get started. They have a full 70-question practice test that perfectly mirrors the real NNAAP exam, plus free study guides covering every single topic on the test, and flashcards to help lock in all these key terms and concepts we explored today. Everything you need to pass is in one place, and it costs absolutely nothing. Head over to certprepacademy.com right now. The link is right down in the description.
Next up will be episode 11, which is the final episode in this series.
We will be tying together the last crucial pieces of the AIDS role. But before we go, we want to leave you with one final thought to mull over regarding psychosocial care.
Consider this. Psychosocial care isn't just extra emotional fluff that you do if you have spare time. It is deeply biological. Studies show that when a resident feels validated, heard, and socially connected, their physical body actually responds. Their cortisol levels, the stress hormones, drop significantly.
Because of that, their physical wounds heal faster, their blood pressure stabilizes, and their immune systems are measurably stronger.
The way you speak to them, the way you listen to them, and the dignity you provide is literally a vital part of their physical medicine.
So, going back to where we started today, the metaphorical X-ray machine might be broken when it comes to human emotion. The waters of mental health and dementia might be murky and confusing. But your empathy and your communication, that is a precision medical tool. Use it well. Thanks for joining us on this deep dive into the source material, and we will see you in episode 11.